All right, Chapter 34. In Chapter 34, we'll look a little bit more at mechanism of injury, discuss a little bit about some of the specifics to assessing the trauma patient, and then look at some trauma triage criteria and help us make better transport decisions. So, as with all of our chapters in the text, simply watching and listening to the lecture is no replacement to reading and studying it on your own, so please do so. The standard that applies here is that the AEMT will apply fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely injured patient. We're going to be looking into the pathophysiology, the assessment, and the management of the trauma patient, and including things such as trauma scoring, rapid transport and destination issues, and then looking at the transport mode. It's only a handful of objectives to this chapter. Those are found on 766 and 767 in your textbook. So in introduction, we have to be prepared to respond and properly manage our trauma patients. Trauma is an injury to the body resulting from external forces. So things including fire, explosion, cuttings, shootings, beatings, all those sorts of things, falls, horrendous crashes, all these things can potentially lead to trauma. In some situations, including in this textbook, they also include the environmental emergencies as trauma, because when you look at heat and cold, those are actually forms of energy or an external force, so they include that as a traumatic injury. Traumatic injury affects people of all age groups and can occur at any environment at any time, and we have to simply be prepared to respond to and appropriately and properly assess and manage these trauma patients. So when we look at things such as kinematics, kinematics is a branch of physics that studies how objects in motion are affected by outside forces, how energy is distributed when they collide. So this basically comes from the word from the concept of kinetic energy. So kinetic energy is the energy of motion. So we have things such as the law of inertia that may also apply. And in this case, it's showing how energy is passed from one thing to another. So the law of inertia, you can see this on page 768 in your text. It's Newton's first law of motion, or the law of inertia, states that a body in motion will remain in motion, and a body at rest will remain at rest unless acted upon by an outside force. So for this example, the car is in motion, the person in the car is also in motion, the stuff, in this case looks like a gift, are also in motion in the car. However, they can operate independent of each other. So in this case, the car hits the tree, the person hits the inside of the car, something debris inside the car hits the person, and then there's even more collisions that we don't often think about. The person's internal organs are colliding with each other or with the walls inside the body. So I mentioned what kinetics and Newton's first law of motion are, and how this is really how traumatic injuries occur. Because if we were constantly in motion, nothing ever was acting upon us, so we didn't stop, we didn't slow down, anything like that, we really, collision really wouldn't be nearly as much of an issue. But when we have those things such as a stationary object like a tree, the tree in most cases will win, simply because it is quote-unquote immobile. It's not going to easily give way and move. It's not like it's on wheels or anything. So it's going to be much more difficult for energy to continue on through the tree. So in that case, the energy actually gets kicked backwards, and that affects in this case, vehicle and content. So the law of conservation of energy can neither be created nor destroyed. It is simply changed from one form to another. So that being said, if we look at something like when we burn something, so if we're burning something, we've taken the stored energy and created it. Now heat is a byproduct, and potentially light, and so on and so forth. So the energy is there, it just has to be activated in some cases, or in the cases of most of a traumatic injury, has to be passed from one place to another. Kinetic energy is a function of mass or weight and velocity or speed. So we know that something that is traveling very fast and is very heavy is most likely going to create a lot of injury, whereas something that's very light but it might be traveling very fast, chances are less that it's going to create a lot of significant injury. Now, it may create an injury in having smaller injury pattern to it, but it's not going to have nearly the impact that something very large and heavy is going to. Newton's second law of motion, that force equals mass times acceleration or deceleration. So this is basically just re-explaining this. It's looking at how does this energy continue to be passed on? Where else does it go? Who does it affect? What does it affect? So when we see these changes, and how do we change some of this motion? So we can decelerate. If we decelerate, something has to change. What changes is we apply the brakes. The brakes get hot. That heat is a byproduct of the energy. So we look at different types of trauma, and some of those types that we look at are usually blunt trauma and penetrating trauma. These can have some variations on them. Blunt trauma is an object contacting the body causes energy to be either transferred directly or indirectly. So in most cases, this means that a larger object has struck the body. It's usually at a lower velocity than many of our penetrating traumas, but not always. The direct injury would be a blunt trauma caused by contact between the body and the object, so a person struck by a vehicle. Indirect energy, if enough energy is involved in the contact with the body, energy is transmitted through the tissues and the injuries occur deeper within the body. So we'll take, for example, getting hit with maybe a baseball bat. So if you get hit by a baseball bat in the chest, we would expect there to be some soft tissue damage to your skin and potentially some damage to your bony structures and your musculoskeletal system. However, that force can also cause enough rattling around and moving around in there that it can cause damage to the lungs and cause damage to the heart, to the greater vessels. So that would be an example of some indirect energy. Now we may have a penetrating trauma, and that penetrating trauma is an example of when something strikes the body, usually splits the tissues. So it usually enters the body. So blunt trauma actually can cause open injuries, such as a laceration. Sometimes the force alone causes that skin to split. In cases of penetrating trauma, that object itself is actually progressing and protruding through the body. So in this case, we're seeing that a bullet has struck this person. And we have actually a good example of cavitation that's occurring here in the second picture. If you look and compare it to the third picture, in the second picture it looks like the wound is much larger. Well, that cavitation has caused damage to those tissues out in that area from the shock wave or the force. The permanent cavitation that occurred there is that damage that was directly in the path of the bullet is destroyed. Now, you may be able to regenerate and whatnot, But you can get this temporary cavitation, kind of like throwing a pebble into the pond. We see the ripple effect, but then the ripples go away. That same ripple effect here is demonstrated in picture B. So penetrating trauma, the object is driven into the body, breaks the skin, and it enters the tissues itself. Whereas if you are struck with a ball bat, the bat didn't really enter the tissues. It may have split the skin, but it didn't truly enter the tissues. So in most cases, when we're talking a penetrating trauma, we're talking either a blade or a missile of some sort that is used to transfer energy. So a blade, such as a knife, sword, whatnot, or missiles such as an arrow, a bullet, those sorts of things. A dart would cause some penetrating trauma. So, and then we have, again, the cavitation issue. So we have temporary cavitation and we have the permanent cavitation. So some of that shock wave effect of the surrounding tissues is part of the temporary cavitation. We also have to take into consideration some things depending on the object, that we may have a cone of injury, as demonstrated in the case of this knife. The cone of injury is because we have a lot of unknown. There's a lot of unknown. So if you get stabbed and somebody pulls the knife out after they stab you, we see a wound when we show up. And it's going to be, we'll say the width of the knife blade is 3/4 of an inch. So we may have a 3/4 of an inch or a slightly larger laceration or puncture penetration wound there, but we don't know in many cases what truly was the angle. So when we look at this cone of injury, we consider what could potentially have been damaged. So if we're talking many people, if we were to stab them with a 1/2 inch blade right between the nipples, maybe even slightly off to the left, a little 1/2 inch blade is probably not significant enough to do any damage to the heart. But in which direction does it go? That remains still to be seen. So if we were to be stabbed with a 4-inch blade, same spot, right between the nipples, just maybe left of the sternum, the chances are pretty good that they could hit our heart. But again, some of the unknown is how deep did it truly go in, and in which angle, which direction. Did it actually kind of skim off of a rib and actually go almost parallel to the width of the chest as opposed to perpendicular? So this is something that has to be considered, is what is the possible, what is the potential? We also look at speed, whether we're talking about low velocity or medium velocity, high velocity. So the speed of things. So we may have low velocity injuries that may come from something like a knife. So something that would be hand driven, for example. We may have some medium or high energy or medium or high velocity mechanisms that come from the various firearms. So handguns and some smaller caliber rifles typically are medium velocity because they produce enough energy to cause injury beyond the immediate path, and high velocity are caused with high velocity rifles, high powered rifles that are generally used for hunting. So they'll have a higher caliber ammunition and just have simply more speed and force behind it. So some of that is going to determine how far is this going to go. How far does this projectile go? So most people are familiar with a .22 rifle, or you could use 22 handgun, really doesn't matter, 22 caliber firearm. And most people look at the bullet from a .22 caliber and think, yeah, well, that's not very impressive when you compare it to something like a .45 caliber cartridge. It's a significantly larger cartridge, and people are like, wow, now that's probably a little more impressive. A .22 easily will kill a person. it has to go in the right area. I've had several patients commit suicide by shooting themselves right through the temple with a .22 caliber handgun, where there is enough velocity and enough power behind it that it actually enters the skull, but there's not enough velocity and power behind it in most cases that it exits the skull. So it bounces around in there, shreds the brain, and that's the end. Whereas if somebody were to take a .40 caliber or .45 caliber handgun, put it up to their temple, shoot themselves in much the same way that they do with a .22 caliber, believe me, there's enough power, there's enough velocity behind that projectile that it's going to go in a little hole and it's going to come out in a big cavity on the other side. Both of them get the job done. If I have to respond to one or another, I mean, yeah, the .40 caliber is cool to look at. The .22 caliber is not a whole lot to look at, but you know what? It's a heck of a lot easier to clean up. So, not to mention, penetrating trauma is a infection risk. So we don't know what was on the outside of that. So, you know, did they roll their bullet in dog crap before they loaded it? You know, you don't know what was on the surface of your skin. Had you just been out rolling around in dog crap and then just got shot, and now part of that's now come into your body. So there's the high infection risk because, you know, we don't live in a sterile environment. Very few things around us are actually sterile. So we determine the length and the width of the object that penetrates the patient's body. Sometimes it's easy. We can find the weapon and have a pretty good idea. In other cases, we have to rely on history alone. So we talked about medium versus high velocity weapons, and in most cases, you know, a lot of medium velocity weapons will do a just fine job of creating a lot of havoc in the body. High velocity in many cases might just pass right through. All right, so attempt to determine the caliber of the weapon that created the injury, the distance between the weapon when it was fired and the patient. And in most cases, if we're talking projectiles or missiles, we may be looking for both an entrance and an exit wound. We may not know which is which. They're not always easy to determine which is which. Most people think, like, if you get shot, the entrance wound, you know, is going to be pretty clean. You know, yes, it's going to bleed, and the exit wound will be a little bit more ugly and probably have a little more tissue damage from tissue protruding out, whereas you might have tissue actually sucked in from the entrance wound. And sometimes that is the case, and other times it's not. It's not always cut and dry and very simple. When we talk about a caliber of a weapon, we're talking about size. Caliber itself has to do with the fraction of an inch in hundredths of a fraction. So a .50 caliber cartridge is a ½ an inch across. So it's actually 51/100ths of an inch thick. So that doesn't describe the length, it describes the width. Some of the more modern weapons coming out of Europe, primarily, they've come to the United States now too, but are actually measured in millimeter. So when you hear about 9mm, that tells you the width of that cartridge or that bullet is 9mm. So it's 1 millimeter shy of a centimeter across. The other thing about entrance and exits is we don't always know that it was a straight path. Sometimes we'd like to hope that with high-powered, high-velocity weapons, in many cases it is a nice straight path through. But you get those medium or lower velocity weapons, and you get that tumble or the ricochet effect that's going on there. You know, we've had people that got shot in the leg and have an entrance wound in the leg and an exit wound in their shoulder. Because it's bounced around. Sometimes you don't even get an exit wound. Again, like with that .22 caliber, may not have enough energy to actually leave a certain part of the body. So you need to be suspicious of any underlying internal injury when a significant mechanism of injury and external injury are present. So you have to be suspicious. You have to be a detective and say, okay, what maybe was in the way here? What maybe got hit? Maybe what got damaged during this process? When penetrating trauma is present, it's vital that you identify both that the wounds are either present or not present. If you don't find one, you don't find one. But if you didn't look, that's an EMS sin. So in many cases, these people get stripped completely because we're looking for any exits that might be there. So it can give us a lot of information, and it can make us think twice about what might be injured. But again, remember, they're not always going to both be there, but you got to look. Remember, scene safety remains paramount. So if we would run into something like this, we're not going to get to this patient's house, or we're not going to get to that vehicle probably for a little bit here until somebody gets in here and gets things a little bit more secured and safe. You know, we've got a fire, that's a big problem. We've got down power lines, that's a big problem. You know, and it's hard for us to tell if there's any other extenuating circumstances with the vehicle here. So. All right, so as you're approaching your traumatic injury patient, of course, take your standard precautions. At least gloves, and in many cases, different types of face protection, including your eyes, are probably appropriate. Ensure that the scene is safe to enter. Remember, in many cases, these can be things such as domestic violence or a type of an assault. So you have to think, you have to be careful, you have to be observant of things that are going on. Of course, we're going to identify our number and location of the injured patients. Sometimes it's not easy. Assess for mechanism. Consider additional resources. This is something that a paramedic may be able to assist with. I'll be honest with you, in many trauma cases, there's not a whole lot extra that paramedics can do. There's a couple of specialty techniques like doing a cricothyrotomy, which is opening an airway into their throat, or decompressing a patient's chest who has pneumothorax that are beyond the scope of an AEMT and in the paramedic scope. But other than that, in most cases, just simply the pathophysiology that a paramedic has can prove beneficial, but the only other real thing that comes into play skill-wise is some extra medications when it comes to pain control, analgesia. We don't carry, as paramedics don't carry, we don't carry blood, we don't carry a lot of other medications that really benefit trauma patients. Medications benefit medical patients, but most trauma patients, they need a knife, they need a surgeon. If the scene is unsafe, don't go there. So we're going to look at mechanism of injury, the forces and the energy that caused the injury. So what happened here? You know, was it a fall? From how far? Did anything break their fall? You know, was it a vehicle crash? Were they restrained? Were there airbags? Was there an explosion? Was there anything between the patient and the explosion? So some questions. We've always asking questions. So it's important to identify the forces that the patient sustained, if we can. Sometimes we can't. Sometimes we have the explosion, and it's hard to identify, to actually pinpoint or say, here's how much force there was behind that. But we can look at things like, were there trees knocked over, was there windows broken out, so on and so forth. Each MOI typically has a predictable pattern of potential injuries associated with it, as long as we're able to clearly identify it. And this will usually help us formulate a list of the potential injuries based off of that MOI. That's why we study it. So in this case, we have a vehicle collision. It's hit a tree. We would expect that most of the force would then continue forward and then, in true whiplash fashion, bounce backwards. So it's usually a fairly linear approach when you got a collision like this. If it's a direct head-on, fairly linear approach, that it goes forward and it comes backwards, and that helps us to identify some of the potential here. Well, if we continue to look at this, and we can think about this, if they're unrestrained driver, then the body comes forward. So the first collision we talk about is is the vehicle colliding with whatever else it collides with. And this is obviously in the case of a motor vehicle collision. We have a second collision. This is the patient's body colliding with the inside of the car. And in this case, the body hits the steering wheel. It should give a strong suspect that there's going to be chest injury here, okay? So we've got potential for sternum, rib fractures, of course musculoskeletal injury can kind of go with that. But what else is underlying? The heart actually has a little ligament that restrains it to keep it from bouncing around too much. Can we rip that ligament? And if we do, that ligament's associated with the aorta. That's kind of a big deal. So if we rip the aorta, we know that people don't do too well. Can we contuse the rib? Contuse the lung? Did the rib fracture, or a rib fracture, and did it actually then penetrate the lung, so we now have a pneumothorax? And then the third collision we have is when the internal organs collide with the body. And I kind of alluded that to the end of the last slide there, that we have things bouncing around on the inside. So the heart comes forward, the gut comes forward, even the brain. While there's not a lot of space up in there, there is enough space created when we have changes in velocity that can create enough of a cavity that there can be a bounce. So motor vehicle crashes or collisions, they tend to steer clear from MVA, now motor vehicle accident, because we know that there's a certain degree of them that aren't accidental. So motor vehicle crashes or collisions is the leading cause of death in people from age 5 to 44 in the United States. Patient's vehicle collides with an object or another vehicle. The patient inside the vehicle is forced to decelerate, hopefully by a restraint system of seatbelts and airbags, or they will collide with the interior of the vehicle. So yes, there is going to be a very minuscule slight delay before some of your devices engage, whether that's the seatbelt or the airbags deploying. But it keeps you from traveling nearly as far as you would if there was nothing at all there. So internal organs of the patient can collide with one another inside the wall of the body. We've talked about that. And the collision of those internal organs can cause bruising, laceration, tearing. We know when we talked about abdominal emergencies that solid organs, and this is pretty true of all the organs, solid organs tend to be very vascular and bleed a lot. Hollow organs tend to have substances within them that aren't particularly wonderful to dump into other parts of the body. In the case of the heart, we kind of have a double whammy. It's not that the blood is dangerous to the body, but if we lose it, it's a major issue. So we have obviously a frontal impact collision here. This vehicle is collided with something else. What can we tell from this? Well, it looks like we've had some pretty impressive damage to above the bumper, so it's possibly collided with something larger than itself. So maybe it hit a semi, the back of a semi. I mean, if we look at the bumper reinforcement there, it's actually pretty straight. So it looks like we've lost a lot of the sheet metal and stuff above it, including the fenders, the hood, and whatnot. It's hard to say what the white sheet is there, if they were using it simply as a way to kind of respect some modesty. I can't imagine that there's actually a fatality under that that's protruding through the windshield. But we do have a broken windshield. That makes it tough. We don't know for sure, was it damaged by the patient's head? Was it damaged by the force from the sheet metal, from flying objects, whatever? But we can see the rest of the car, all in all, is in not terrible shape. They've removed the door for extrication purposes, and obviously it lost a lot of fluids, and that's where the floor dry is kind of coming from there. But all in all, while it looks a little dramatic from first look here, it's probably not as bad of an accident as the first gut feeling. So here we're showing an unrestrained driver traveling in the vehicle. Part of him, his chest will stop when it hits the steering wheel, steering column. I have seen people hit the steering wheel so hard that it actually breaks the steering wheel off. And I've gone to extricate people from vehicles, and the ring of the steering wheel broke off. The spokes stayed there, but the ring of the steering wheel actually was laying down around the steering column up against the dashboard. The head will generally come forward until it collides with something, and in this case the windshield. And it's possible that the knees will continue forward until they hit the dash. The feet can get tangled up underneath. Sometimes the seats get broken off, and that becomes another potential issue. So here we show our impact points, and with the head hitting, yes, we have the chance for frontal area injury, but also maybe now some neck problems or some occipital issues from either the brain bouncing around inside, the head getting whiplashed backwards or hyperextended. Of course, we have the potential for the chest, and then even the abdomen and the hips. This is called the up and over pathway. A lot of it is going to depend on what that vehicle strikes, and obviously in this case we're dealing with a lot more upper body trauma. We also have a down and under pathway, which we'll talk about here shortly. It typically has to do with more lower body injury, but motor vehicle crashes or collisions head-on, most of the energy is conveyed. We have the highest amount of energy conveyed when we have a two-vehicle head-on collision. So if one vehicle is stationary, we have half the energy. It's still being passed, but so a vehicle traveling 55 miles an hour and another vehicle traveling 55 miles an hour, we're now talking about a grand total of 110 miles an hour worth of force. Whereas a 55-mile-an-hour car strikes a wall or a tree or something, yes, it's bad, but we have half the overall force involved. So with that up and over pathway, the patient collides with the steering wheel, the head moves upward, strikes the windshield, and we typically will see chest, head, neck, and abdominal trauma, potentially even partial ejection through the windshield. Now with the down and under pathway, so the patient collides with the bottom of the steering wheel, so it can cause some abdominal injury, can cause some hips, some legs. The legs can come forward, hit the dashboard. They can have some femoral issues, issues with the knees, and then they may also have chest or abdominal injuries as well because they are still going to strike with the steering wheel. When we have something like this where we have a starred windshield, that star in the windshield gives us evidence, particularly in this case when we look, we can see it's a central strike pattern right there in the middle. We have to be strongly suspicious that that's probably a patient's head that hit that. That it's not an absolute. Could have been a foreign object. Could actually have been something on the outside that hit it that caused it to star like that. If we look down in the corner of the cab here underneath the windshield here, underneath the steering or the windshield wiper, we can see there's another major impact point down there. So that's kind of it's kind of an oddball here, is what exactly caused this. So it'd be better if we could see a bigger, broader picture. So with frontal impact MVCs, the amount of damage to the front of the vehicle, if it is more than 18 inches, it is considered significant. So if the front bumper or any other part of the vehicle there gets pushed back more than 18 inches of where it normally should have been, that is considered a significant impact, and that patient should be considered at least for transport to a trauma center. Scarring or shattering of the windshield is another one because it's showing some probability of somebody has struck the windshield. Bending of the steering wheel or a collapsing of the steering column, another one. I can remember an accident a number of years ago I went on. A person was ejected through the windshield. They were unrestrained. And as I approached the vehicle on my way to the patient, as I look in, I can see that the steering wheel is no longer round. It's actually bent into a U shape or a V shape, more like a taco shell that happened when this person was ejected through the windshield. Their leg actually grabbed onto the steering wheel and pulled the bottom half of that steering wheel up into that U shape. Sure enough, when I got to the patient to assess him, which was a traumatic arrest, but when I got to the patient to assess him, did a quick once-over, and his femurs were just absolutely mush. So, damage to the dashboard. Most cases we don't come into contact with the dashboard, so any damage to the dashboard should be considered somewhat significant. And then above signs indicate that potential of injury are high. So when we come into contact with that stuff, be alert to objects inside the vehicle. And I don't want to limit it to just inside the vehicle because a lot of us prefer to drive pickup trucks. Myself included. If I had my druthers, would take a pickup truck just about any day. But I remember my very first pickup truck that I had when I was quite a bit younger. I had a big old 3/4 ton truck with some oversized, not terribly oversized, but slightly larger than factory wheels and tires on it. And my spare included was oversized, and I just had the spare just sitting in the back of the cab, or not the cab, the back of the truck, in the bed of the truck. And then I remember going on a call in which somebody had very similar setup where they had their spare tire just basically sitting in the back of the bed of their pickup, not restrained, and they had had a collision with a tree, and their spare tire came up out of their bed and through the back window of their truck and caused some pretty horrendous damage. So back in my day growing up, we didn't have MP3 players of the day. We had cassette tapes, and before that they had 8-track tapes. But so we had cassette tapes, and I remember many of my friends. I had some in my vehicle, but many of my friends had these big 100, 200 cassette tape cases that they had in their vehicles, and just imagine that flying around the vehicle should you get in a collision. Book bags, and if you're taking a potluck dish somewhere, now you've got it, a steel or a glass pan. Unrestrained car seats. Who else? Who knows? I mean, even some purses just have so much stuff in them they could just fly around. Now let's think twice about this, about how many things in the back of our ambulance are unrestrained. I would be highly surprised if more than 10% of us could say everything, our cardiac monitors or our defibrillators, not even everything, our cardiac monitor or defibrillator is well secured in the back of our trucks. Most places they're not. Most places they're intended to be easily gotten to when we need it. So to unlock it out of some sort of structure tends to break our original thought behind it, easy access. But in the couple of ambulance accidents that I have either seen or been in, it has involved a cardiac monitor defibrillator getting launched a significant amount in the back of a truck. So. All right, and let's see, chest. Impact on the chest. On impact, the chest will strike the steering wheel or dashboard. Obviously causes soft tissue and bony structure issues, but also extends to potential for soft tissue on the inside. So if we have the sternum or ribs break, that can lead to significant internal bleeding. Remember, under each rib, there's an artery, a vein, and a nerve that travels underneath each rib. So fracturing that rib and just slightly displacing it can lacerate that artery and or vein. So the heart and lungs are highly susceptible to injury. They're fairly delicate tissue in the grand scope of things. Not to mention the way that some of them are kind of restrained, whereas through the hilus or the hilum, there's a particular spot that they're kind of kept still. But for the most part, we need lungs to move back, expand and contract. We need hearts to expand and contract, so they can't be nicely secured. The abdomen, we want to consider damage to the steering wheel and or the dash. High index of suspicion. Vital organs within their cavity can compress and shear. So we can hit a steering wheel, push in on the ribs, pushes in on the liver, causes a fracture of that liver, causes some significant bleeding. Their head, they strike the windshield. We have to suspect skull fractures. Lacerations will they'll look very ugly because anywhere you grow hair, you have a significant blood supply. So you have the potential for there to be lots and lots of dramatic blood going on. And then if we have a head injury, there's a good chance we also have a spinal injury. So in this case, we're going to look at a rear impact collision. And this rear impact collision really kind of pushes things out from underneath the patient. And a lot of times they get thrown backwards. You may also get a whiplash collision here, or whiplash injury here, as you get thrown one way and then you bounce another way. So this is following acceleration. The occupant decelerates. So when you're hit from the back, it pushes your vehicle forward, accelerates it, and then all of a sudden things start to decelerate and you flop forward. And we have, again, kind of the up and over appearance of the injury pattern here. So the vehicle is struck from behind. So let's think about this picture on page 775. That's the little red car here, this one. If we think about this for a second, you actually have a head-on or frontal and a rear impact collision. You have two collisions. You have two separate amounts of force that are being involved here. You may have two completely different sets of injury pattern based off of which vehicle the patient was in. And that whiplash injury, we have a hyperextension that can lead to a serious injury of the soft tissues, the spine, and or the spinal cord. So it is possible that you'd be hit from behind, that you could fracture some vertebrae and actually put some pressure and damage on that cord. So we also have something that occasionally occurs both with frontal and rear impacts. It's a type of injury that's called a coup contra coup injury. Coup, C-O-U-P, C-O-U-P, not coop, but coup, contra coup, which is C-O-R-N-T-R-A, contra, no, C-O-N-T-R-A, contra coup, C-O-U-P. So coup contra coup injury. This is when the brain actually bounces around in the skull, so you get an injury on the front of the brain and on the back of the brain. So coup contra coup, because the brain bounced around inside. So we get a frontal lobe injury and an occipital lobe injury. Here we have a lateral impact. Lateral impact, not a good deal in many cases. This is usually what's called the T-bone collision. But there's usually much less protection for people in the T-bone or the lateral impact collision, because yes, there may be some steel structural components in the door of the vehicle, the rocker panel of the vehicle, and so on and so forth. there's not a big hood in front of you or a big trunk behind you. There's not the lengthwise high structural steel that composes most frames to most vehicles. So you have so much less between you and whatever else is striking you if you're the recipient of a lateral impact collision. So, and this shows kind of how that mechanism plays there. We get the door, which is kind of represented there in the kind of pinkish red color, that's being pushed in, and it causes the actual direct impacts there onto the arm and the leg, and of course the hip and the chest and pelvis and whatnot. But then we also get some whipping around there, some kind of indirect injury from the head actually kind of getting whipped over and knocking out the window, the side window. So we look at that intrusion into that passenger compartment of the vehicle and at what location. That helps give us some clues as to what may actually be injured. Remember, we can't classify them all together in one lump sum because getting hit by a smart car, if you're driving your pickup truck, getting hit by a smart car, probably not going to be much of a big deal to you. Probably the other guys aren't going to figure out so well. But you get hit by a semi, and the weight is different, and the point of impact is different. That smart car, heck, it might strike, below the level of the seat, whereas in the semi, you're going to have damage all the way up and down. So the injuries, most common things seen, fractured extremities on the side of the impact, lateral chest trauma, hip fractures, head and neck from lateral injury, and then don't forget, do you have a center console in the vehicle? Did the center console give way, or did you actually get a sandwiching effect that occurred from being struck in the door and then being stuck up against that center console? Two people in the front seat. That's potential for the two front seat occupants or the two back seat occupants, whatever, to cause injury to each other because they were kind of more or less bouncing around inside the compartment. This shows us a rotational impact where we actually kind of got spun out there, more or less. When we're talking rotational impacts, it's difficult in some cases to predict what we get going on there, but remember we have twisting forces. Twisting is not good. When you have twisting forces, you have forces going in opposing directions on the same object. So twisting can lead to significant injuries of some of the extremities, but particularly when we have two different forces twisting around in, say, the neck or the internal organs. Rollover impact, I got to tell you, rollover impact, all bets are off. It's so hard to speculate about what forces might have played on the patient. Were they restrained? Were they not restrained? Remember, they get thrown around in the vehicle, which this kind of demonstrates how, as that vehicle rolled over, that person tumbled all over inside the vehicle, not to mention whatever else is rolling around in that vehicle with him and potentially striking him. So we've got forces of every kind. We've got some twisting. We may have some lateral. We may have some direct frontal or posterior. So unrestrained vehicles, they can easily be, or unrestrained individuals can easily be ejected from rollovers because there's so much force and there's so many potential exit points now from this tumbling. It's really not uncommon for rollover patients that are unrestrained to be either fully or partially ejected from a vehicle. So once a patient or part of their body leaves the vehicle, their risk of death climbs exponentially. Pedestrian versus vehicle collisions, or cyclist versus vehicle collisions. Things that we have to keep in mind, of course, speed of the vehicle impact. There's a number of driveway collisions that I've been in on, where a vehicle versus child, vehicle versus tricycle, whatever, and it actually ends up being, there's a certain pucker factor when you hear that call, but it ends up being, all in all, turns out well. Whereas, I've also seen small children on bicycles on a highway struck by a semi that doesn't turn out very well. So part or parts of the patient's body that are struck. Remember that the patient's bodies are different, just like vehicles are. If an adult of my stature, so I'm 6'2", if I'm struck by your standard everyday sedan or coupe, in most cases I'm going to turn away. If I see the collision coming, I'm going to turn away, because that's psychologically what adults do. They turn away to kind of shield themselves, and it's going to hit me in about the knee, and it's going to throw me onto the hood of the car, with the potential for there to be upper body injuries from that. Whereas a small child, a 2 or 3-year-old or 5-year-old even, they get struck by the vehicle, the bumper hits them in the abdomen or the chest, and it throws them down, and they go under the vehicle. So we have substantially different forces that are in play here. The distance that the patient was thrown following the impact. So if we are just knocked over, we've all fallen down. So if we're just simply knocked over, in most cases we end up not too bad a shape, but if it throws us 10, 15, 20 feet, well, now we're talking almost the equivalent to a 1 to 2 story fall. Body parts that struck the ground following impact. So if I'm falling and I throw my arms out in front of me and I catch myself, I shock absorb some of that energy before I strike the ground. Whereas if the first thing to strike the ground was my head, it now has to try to absorb that, and it doesn't fare nearly as well as extremities do. The type of surface in which the patient landed. Did I get thrown onto a concrete street, or did I get thrown into a nice fluffy bush, or onto grass? Those are going to be softer. There's more give. When you have give, it lessens the bounce back of the energy. So children, adults, like I said here, when a person is about to be struck, he will tend to turn his back to the coming impact, absorbing it either on lateral or posterior side of the body. And as the vehicle impacts, he's lifted off his feet, and forward movements to the vehicle, he may impact the windshield or be thrown up and over. Pediatrics, on the other hand, they freeze in place if they see they're going to get hit. So the younger the child, the greater chance is that they're going to be looking directly at the vehicle as it hits them. So if we have a high-speed collision going on here, very possible that the person just slides right up over the hood, the windshield, and then the roof of the car, right off the backside. If the driver decelerates by applying the brakes, that person will then roll forward off the hood of the car and strike the ground again. Motorcycle collision. So drivers of a motorcycle are obviously much more exposed than those of an automobile. People in automobiles obviously kind of have a steel cage around them, whereas all the structure of the motorcycle is under the patient when they're riding a motorcycle. If they're not wearing a helmet, they're at a much greater risk for sustaining a head injury and increased morbidity and mortality. Head-on motorcycle collisions, the rider typically thrown over the handlebars, which anybody going over handlebars is at greater risk for femur injury and the possibility for even some pelvic fracture. And then it's going to continue until it comes to rest, striking the ground. Lateral impact motorcycle collision. The driver is struck by the vehicle, usually sustains an injury to the leg on the side of the impact, and then that driver usually loses control and then crashes. And it's hard to say. It could be a rotational style crash that they're involved with. They could flip over the handlebars. It's tough to say. You can have an ejected motorcyclist. Most motorcyclists hit at more than just a couple miles an hour are ejected from their cycle, even though it may not be terribly far. And when a helmet is not worn, they have that increased likelihood of head trauma. Yes, there's the possibility of there being musculoskeletal injury, but from the head being protected by the helmet, it might rock back, kind of whip back, and then the helmet can actually play a part in maybe some potential spinal injury. But in many cases, the patient's brain will be saved, or at least not nearly as involved. And but once you cave in the skull, that's not a good thing. So here we're seeing an example of a direct and indirect injury basically as somebody who's maybe fallen from a height. The direct injury in this case occurs at the patient's foot, so the calcaneus or the heel bone there, and then that energy is passed upwards because the weight of the patient's body is still coming down. So that force is transmitted upward, and it can affect some of the weaker areas above. That's not to say it's not going to fracture tibs and fibs and femurs and pop pelvises and whatnot, but the more delicate bones up the line there are those of the vertebrae. So we can get these compression fractures that occur from the energy being forced upwards from bone to bone to bone to bone to bone. Or it can wipe out the discs in between. So when we're looking at falls, we're considering the height of the fall, the body part that impacted the landing surface first, which that shouldn't be earth-shattering to anybody. We fall on our hands, we fall on our feet, chances are better that we're not going to suffer as much core trauma. The surface that the patient fell onto, again, grass, bush, over concrete, gravel. Did anything break the fall? So we've had people who have fallen from scaffoldings. So as they start to fall off scaffolding, they start to kind of get tangled up. Well, the tangled up, yes, it does probably cause some potential for extremity injury, but getting tangled up in the scaffolding actually slows your rate of fall. So in the grand scheme of things, can actually be better for the person in the long run. Blast injuries, so explosions, fireworks, whatnot. Of course, you need to make sure that the scene is safe, that we don't have any potential additional explosions. Of course, we have the potential for them, but so when we're talking about these explosions, we need to, of course, take our own safety into consideration. We generally look at 4 major phases of a blast injury. The first is the primary blast injury. So this is the pressure wave from the explosion directly related to the force of the explosion. So that pressure wave can cause things to pop, things to explode. So if you had lungs full of air, that blast, that pressure wave hits you and causes things to pop. It also can cause other damage, other ruptures of vessels and whatnot. We have the secondary blast injury. This comes from debris. So that debris flies around, nails, rocks, boards, whatever, flies around and strikes the patient. So commonly causes lacerations and impaled objects. It can cause some fractures and whatnot too. We have tertiary blast injuries, and this is when that pressure wave and the debris impact the patient and they are thrown from the explosion. So this tertiary injury is actually those of being ejected or of a significant fall. So the primary blast injury popped a lot of stuff on the inside. Secondary blast injury, we were getting hit by things, pelted by things as we were flying around. That tertiary injury now is as we hit the ground, we hit the wall, we hit the fence, whatever. That's the injuries we suffer then. And then the quaternary blast injury can be from some of the environmental conditions following the explosion. So crush injuries, things have fallen onto us after we hit the ground, the wall, whatever. Toxic inhalation, fire, and for that matter, you could also consider the potential for infection. That probably we could look at that as being called the quaternary blast injury, but the secondary effects that you have following, so things like infection and fluid shifts and whatnot. So we need to look at significant mechanisms of injury. What are significant mechanisms of injury? What are things that we want to be concerned with right off the bat? So these are things that we almost, they're not an automatic, but they're an automatic strong consideration. So significant mechanism of injury. So this is one that we're saying this is either something that can cause a life-threatening injury or has the high potential to cause a life-threatening injury. So these are patients who often require higher level care for the treatment of their injuries. So your standard level 4 hospital in your local community, it may not be the most appropriate facility to receive these people. We want to try to transport patients to facilities with surgical services. So levels 1, 2, and 3, preferably a 2 or a 1. So here's a good little list here. Ejection from a vehicle, death of somebody in the same vehicle. There is some debate on whether that actually should be death of somebody in the same incident. Because if there was enough energy to kill one person in this incident, there was enough energy to kill everybody in this incident. So there's been some discussion on that. Rollover motor vehicle collisions, high-speed collision greater than 40 miles an hour, pedestrian struck by a vehicle or a cyclist struck by a vehicle, falls of greater than 20 feet for an adult or 10 feet for a pediatric patient. There's another way to look at this. Some people say 3 times their own height. Motorcycle and rider separation, so the motorcycle rider is ejected. This is if, basically we're not talking the motorcycle collided with a vehicle. Penetrating trauma to the head, neck, torso, or proximal extremities, meaning anything above the knees or above the elbows. And then significant blunt trauma to the head, neck, or torso. We know that head, chest, and abdominal injuries kill you, so that kind of goes along right with those. Less severe injuries can also require our care. They can also require hospitalization. They just don't probably need nearly the level of care, because we don't take every trauma patient to the trauma center for the full Monty of exams and treatment. We have those people who fell down the front stairs. We have those people who, shot themselves in the foot with a low-power rifle, whatever, I don't know. That it simply needs wound care. It might need a immobilization in the form of a cast or a splint or something, but just because they're not on the list for high mechanism of injury doesn't mean that they're not important. they just don't generally need as immediate of a high level of care. There are also compounding issues or comorbid complaints or morbid issues that go along with this. So when we look at people who are maybe chronically ill, they've already suffered a different trauma, people who have multi-systems trauma, people who are on certain medications, hypothermia, those things all can compound the issue even more. All right. I'm going to cut off here for a moment.